Good day, global citizens. Welcome to another episode of Dr. Fajembola'S Opinion. This is a platform where research meets understanding and legacy. Today, I'm glad to bring you an esteemed senior colleague to discuss an issue that is currently affecting everyone globally, especially the global north. Do join me to welcome Dr. Bandara Shashika. Dr. Bandara, how are you doing?
I'm good. Good to be here, as you said.
Okay, I hope I pronounced your name perfectly.
Yeah, you got it right. Yeah.
Okay, thank you so much. So, um, today we are going to discuss this investing in global health, and I'm glad Dr. Shashika Bandara is the one here to discuss this issue with us and to make us understand the different stance on global health leadership. Before we dive into the discussion, as we usually do, let me take you through the profile of Dr. Shashika Bandara. He's a postdoctoral fellow at the Department of Global Public Health in the School of Population and Global Health at McGill University. His research and advocacy focus on global health policy and governance. He collates McGill University's research on policy exemplars addressing structural discrimination to improve health in collaboration with the Lancet Commission on Racism, Structural Discrimination, and Global Health. He is an academic editor of the PLOS Global Public Health Journal. Dr. Shashika received his PhD from McGill University and also Masters in Global Health from Duke University. Dr. Shashika is formerly a policy associate at the Center for Policy Impact in Global Health at the Duke Global Health Institute. Dr. Shashika has worked in human rights policy advocacy in Sri Lanka and South Asia with Law and Society Trust and in collaboration with Forum Asia. He also has experience working in humanitarian settings with CARE International. His previous training includes molecular biology and has conducted cancer immunology research at Johns Hopkins University. That's a beautiful profile, Dr. Shashika.
Thank you. And just wanna slight correction because I didn't these pronunciations. So it's McGill University,
Okay.
where I'm at right now. So including so I'm part of McGill University Department of Global and Public Health.
Okay. Thank
Yeah,
you so much.
yeah.
I used to call it MCQ.
It's all good. Yeah.
Okay. Okay, let's look at what global citizens are saying global health leadership. The first is from Dr. Senia Anishta, where she said many thanks to the expert group on Canada and the future of development cooperation for inviting me to a roundtable discussion on the evolving landscape of global health. Gavi welcomes Canada leadership to help drive global health architecture reforms as the sector adapts to a more complex, resource-constrained global health environment. I believe Canada is stepping up since the US is stepping down on global health leadership. And Dr. Sania is the CEO Gavi. So I believe they are trying to collaborate with other global health actors who are willing, since the US is a bit unstable on global health leadership. The second tweet is from Sabin Institute, Vaccine Institute, where they said global health is not standing still, it is rebalancing. If we stay focused on evidence, equity, building trust, and country leadership, this moment of reshaping can be a foundation for a stronger, more resilient immunization ecosystem to protect lives and prevent deaths around the world. The last is from Dr. Tedros, who is the Director General of World Health Organization, where he said, honored to meet Royal Highness Queen Letizia of Spain and showcase how WHO's commitment to reform are strengthening the organization's resilience, mitigating financial risk, and reinforcing our global leadership role in protecting and promoting health. I believe all organizations are stepping up. The WHO, Sabine, and all global health organizations are stepping up in trying to balance global health leadership and architecture and its impact globally. So now, Dr. Shashika, this is a beautiful publication, and I believe global citizens want to learn more and know more, and not everyone can read these publications on disinvesting global health. A lot of people are just going through the news. What is the news saying? And the news says many things. The news says what it's pitched to say. So, um, during the tweets, I was talking about architecture of global health, and people don't even know, okay, global health leadership. Oh, maybe it's WHO. When you ask anyone global health leadership, goes, okay, the World Health Organization. They don't really know about any other thing outside that. So, Dr. Shashika, what is the architecture of global health leadership?
That's a broad question. I mean, it's right now, I would say there's been an evolution of it. So WHO, the UN system, brings together all the countries and it kind of sets norms and standards for global health. And generally, we have all agreed upon, certain basic standards for health that is kind of grounded on human rights, right? So there are inalienable rights for humans, including the right to health and well-being. So the global architecture, on the one hand, is the UN system, which includes the WHO, sets the norms and standards. All of the sort of the resolutions and the plans are sort of supported by member states, which are the countries, and they pass. So, for an example, the recent pandemic agreement, which was passed, came with, had to get the support of all the countries, and there were extended negotiations, and we have passed the pandemic agreement, but they're still working on an annex, right? Um, and then on the other hand, there are other organizations. So Gavi, the Vaccine Alliance, which you just mentioned, and then, Global Fund. So these are other organizations that are providing funds for countries to improve their health. Um, and then we have these wealthy countries that are providing funding through bilateral aid to kind of support, health goals in the world and also in different parts of in low and middle income countries and or even their own countries. So what has happened now, right, as we all know, since 2025 January, is the United States, which is the largest funder in global health monetary wise, which funds about 30% of global health funding at the time, pulled out from all of this funding, kind of creating a seismic shift. Now, this is good and bad. This is bad because it's an overnight pull from the global health architecture. And so a lot of the programs, countries, even people, even within America who depended on or who had livelihoods connected to this global health work was kind of upended overnight. And that's not the way to do it, right? You don't pull a plug from something overnight. So this is not good policy. However, it gives us an opportunity to, like you said, right, like to rebalance the scales, to kind of reestablish a system where we address the fault lines of global health. So, as you all know, global health has a strong colonial history, starting from malaria eradication to support the slavers and their business models and their business priorities. And then this has evolved into what it is now, international health, but it has its roots in many of these exploitative imperialistic foundations. So this is an opportunity for us to rebalance the scales or to reimagine global health by having countries invest more in health, by building an architecture or shifting our architecture to sort of center the voices of low and middle income countries, especially when it comes to the issues that are affecting them. So that is just of a brief overview of the complexity of the global health architecture. Over to you, as I said.
Thank you so much for painting a good picture, an excellent picture for us on the global health architecture. And there is so much information on global health leadership. So, what three things should our audience take from global health leadership? You want them to know about global health leadership?
If you're going to focus on global health leadership now, and if you're thinking of following something, I think I would follow the evolution or the shift within the UN system and WHO and so on, because in the context of how high income countries are kind of interacting with it. The second thing I would follow is money. So you really have to follow the money because funding is essential for everything. So you should
Exactly.
follow the pulling back of money funding from not just the US, but many of the high income countries. A lot of high income countries, including Canada, has slashed budgets. Um, to global health funding. So that is the second thing I would follow. The third thing I would follow is the emerging voices or the reclaiming of the space by the global south. So the African Union is doing a lot of work, convening countries, trying to build a sort of a united voice. And then I know in other parts of the world also there's this leaning towards a regional approach. So following those trends will also be important to see where we are headed in terms of the future of global health.
Thank you so much for that. This discussion is surrounded by disinvesting and also funding. What markers show that disinvesting has begun? Because some people, they are still, as long as they are not affected, they don't believe that there is disinvesting. They believe it's under discussion entirely going around. So what markers show that disinvesting has begun?
I want to say this at the beginning, outset of this discussion. There's a really nice commentary in the Lancet about how we should not just think about this investment as just the end of all things, because countries are coming together to sort of address this, our own countries. I'm from Sri Lanka. Sri Lanka wasn't affected because we were never that dependent on aid, but even the countries that were dependent on health aid are coming together to address this. So I just want to say this at the offset. So going back to your question around markers, I think if you look at the HIV/AIDS, the TB, and many of the other global health program, including sexual and reproductive health, especially in highly aid-dependent countries. So Malawi, for an example, was the most affected in terms of aid. And there's this really nice article on Think Global Health, which is an outlet that compiles expert opinions about and a nice map around how this funding cut impacted the countries in terms of delivering care. So what happens is that when you pull the plug overnight, which as I mentioned is a very poor and almost a cruel policy decision by the US, when you pull the plug overnight, all of these people who are dependent on getting care from a aid-funded structure uh, is affected, right? They're all affected, and their healthcare is affected. And for things like TB, HIV, you need continuous care. You need the health system to function well. So when those things don't function, then their lives are in danger. So a lot of people, there are estimates that millions of people will be affected by these aid cuts. The second thing, which I think is related to the paper that we're talking about, is how the architecture of global health itself will shift. So once you cut funding to research programs, it cuts the pipeline, or it affects the pipeline of building leaders. So it affects our, conversations like this, right? It affects us connecting at a global level, because the opportunities for young scholars to come up on global health training is limited. So it affects the people in the US trainees, right? It also affects the global trainees. It's not just an issue for low and middle income countries. So my hope is that the global south countries and also other parties in different part of the world will step up to address this. Yeah.
Thank you so much for that. The word is step up. Um, there are two words that are emphasized in your paper: isolationist policies. And for anyone listening, for anyone that already paper, for anyone listening, that might be their first time of coming across it. Isolationist policies in global health leadership. Can you give us three examples?
Yeah, so just to define quickly, isolationist policies is to say, uh, essentially, the biggest example we cannot escape it is America, right? Their global health strategy right now is called America First. So that is
Mhm.
the example of an isolationist policies. This is thinking that, we are going to do to prevent everything that is affecting us, and then we don't care about anyone else, right? And so that's an isolationist policy. So one example is this global health policy that US has now, but it's also all the policies that many high-income countries are taking an approach. So they're pulling funding from multilateral efforts, and then they're trying to. A lot of the times, a lot of this funding gets allocated to defense of their country, so military, and we are headed towards a really high increase in terms of armed conflict. So these isolationist policies just looks inward and goes away from the global multilateral efforts to address threats in global health. And I want to say, if you are a person who have been following just the news, doesn't have to be global health news, right? If you've been following news, if you look at the COVID-19 pandemic, any infectious disease, any armed conflict, any climate crisis related challenge, you have to know that, it does not stay in the place that it starts. Every one of us is affected. So these are global crises. And the only way to address this is through global efforts. So when you go towards, America first or France first or whatever it is, you are essentially weakening your own country, your own people, although you think you're doing them a favor. So isolationist policies are going to fail, whether we like it or not.
Thank you so much for that. Actually, from my perspective, I think isolationist policies are selfish because we're in a global ecosystem and whatever affects the global north is affecting the global south. We need more north south collaboration. This is not the time to have isolationist policies because it will help no one. We are living a global crisis, one world crisis. Thank you so much for that, Dr. Shashika. Basically, when we talk about global health leadership, people are looking at the big players, people are looking at presidents, people are looking at the big stakeholders, the United Nations and the rest. And it's so easy for someone like me, or even someone at the grassroots in Sri Lanka, someone at the grassroots in Thailand, someone at the grassroots in Nigeria, who spends less than $1 a day, who even feels unseen by their own governments, to think, oh, what role do I play in global health leadership? So Dr. Shashika, what do you feel a global citizen? Do you feel we will have an important role to play in global health leadership, or we are invisible as some big players might think?
Yeah, so this goes back to the colonial roots of global health, right? I think we have to recognize the foundations of global health, which has always kind of promoted, whether it's intentional or unintentional, I'm not going to get into that, but the way it was structured during the colonial times, it was definitely intentional. Right now, I don't know. So they promoted expertise, knowledge as something that is Eurocentric. So even now we kind of look to the Eurocentric knowledge hub, global north-centered knowledge hub as the standard. So this is a deep fault in global health, and we perpetuate that through many of the approaches that sort of promotes unfair knowledge sharing or does not do justice to the knowledge that is there in the global south. So we call it epistemic injustice. Actually, a Nigerian professor who is now in Australia, Shea Bimbola, has written a lot on this. He has a book called Foreign Gaze. I highly recommend reading it. There's also a nice article called Foreign Gaze as well. So Shea has said, it's essential to center the voices of those who are in those countries as the experts. So that is not happening enough. So this invisibility that you speak of is related to that. So first of all, we shouldn't be invisible. We are not invisible, right? We need to kind of claim that space. And second, I think there are many ways to do it, right? Like, so one of the things that people often get confused about is that when if I'm not at the UN level, if I'm not at these big, meetings, then I'm not visible. That is not true. You can fight disinformation at your own, community. That has a huge impact because nobody else can do it. You can do it, right? If I come in and say to a community as an outsider, these are the disinformation that's going around, they wouldn't believe me, but they would believe you because you're part of the community. Your life is as affected uh, as theirs. So fighting disinformation is a big role that you can play. And then informing ourselves of the trends that are happening, holding your government accountable, right? Like, so when you are informed about these global health challenges, you can hold your government accountable and say, look, invest more in, let's say, universal health coverage so that everybody can get better health care and so on. So, I hope I answered how we are not invisible, how we shouldn't be in the architecture, and also how we can step up.
Thank you so much for that. And it's important to emphasize that an infection starts from one person. Whatever pandemic, whatever epidemic we are facing, it starts from one person. So we are all important. Advocacy starts from one person. So we are all important in the global health leadership. And this is an avenue to tell global citizens, don't think you're not important. Don't think you are irrelevant. Whatever you do affects your neighbor. Whatever you do affects the community, affects the society, and affects the country, contributing to the gross domestic product of your nation. So you are not invisible wherever you are in the global north or the global south. You are not invisible. You are as important as our leaders. So thank you so much for that, Dr. Shashika. We are looking at the United States now, the big player. Do you feel the United States is a bad influence on other high income countries contributing to the global health budget because they are also cutting, the United States started it, cutting the global health budget, funding on health development, especially on the global south. Do you feel the United States is a bad influence as other countries have followed on this trail?
Yeah, I mean, bad influence is oversimplifying maybe because, the whole world is built on the concept that every country has its own sovereign approach, right? So just because in US there's something not like other countries don't have to do it. And they keep repeating that about their sovereignty, about their, originality and all of those things. So I would say US is definitely setting a bad example. We can list the ways, right? And it's growing. Starting from the funding cuts to global health at the top of 2025. And, at the beginning of this year, they pulled out from, over 50 UN organizations. They're just pulling out from the multilateral system. And on the other hand, they're also promoting really dangerous anti-vaccine, anti-public health notions and that are also kind of steeped in at times racist ideologies. So I don't know if you listen to the Senate hearings of the current Secretary of the Health and Human Services, RFK Jr. He said that Black people, African Americans in this instance, should have a different vaccine schedule than essentially white people. So these are like really outdated and racist notions. So when it comes from a person like that, it takes hold, right? Like so. And you don't know what that kind of information can take a life of its own and impact so many different people. So I would say they're setting a bad example policy-wise. What they're doing through funding, how they're navigating, and also starting armed conflicts, and then how they're also spreading disinformation. However, other high income countries, other low and middle income countries are their own sovereign states. I know they're connected to the US. I know they're influenced by US policy. But this is also a moment to stand up, with courage, right? Because this is our future. We don't get to do over. So it's necessary for countries to, step in and find solutions to, improve the global health architecture, and then, bring in more equity into it. So a lot of the voices, the scholars, the practitioners have highlighted how global South countries first need to step up their own domestic investment in health, but also needs to how we need to shift our architecture to center those voices. I said this at the beginning of the interview too, and so this is an opportunity for us to do that. And so, example or not from the US, we can do better as the rest of the world, hopefully.
Thank you so much for that, Dr. Shashika. Now diving into the paper. We're getting quotes from the paper.
Yeah.
Estimated 25 million deaths are projected in the next 15 years due to funding cuts on major global health programs. Most global health programs are in the global south. Can we say we have more than half of these deaths? Can we say more than half of these deaths are expected from global southern countries?
Yeah, for sure. I think a lot of these debts will impact and the systemic challenges and the domino effect of all these funding cuts will affect global South countries. That is not to say that US is also kind of, weakening its own health system by the things I mentioned, by disinformation and also redirecting the funds to their defense and things like that. And I also want to say that we have to be like these are projections, so these are model projections, and we have to do this to see, okay, what is the impact? But these model projections can be shifted, right? This doesn't have to be the one reality we are focused on. This reality could shift by, countries already stepping up and shifting their budgets to invest more in their own countries, by countries coming together and influencing the global health architecture. So while the impact is definitely in the global south and it's disproportionately affecting us, it can be shifted, and it is being shifted. There are efforts being launched by African Union, by different, like there was a meeting in Accra with among African leaders where they made a declaration, right? So there are different efforts that are coming forward. My hope is that they will take hold and you can shift this trajectory of this projected deaths and destruction in health systems.
Thank you so much. Thank you so much for that, Dr. Shashika. I think this is the time for other countries, especially countries in the global south, to step up. We cannot keep depending. I say we because I'm still a global southern citizen. We cannot
Yeah.
keep depending on the global north, on funding and other aids coming from the global north. They can decide at any time we are not. Not just in this regime, in future regimes, they can decide at any time we are not given. So we should be independent. We should be independent to be able to take care of majority of our citizens. So Dr. Shashika, Harvard, John Hopkins, among others, have reduced intake of international students. Do you
Mm.
see a reduction in the quality of future global health leaders from the United States?
No, I don't. That's hard to say. I don't think the quality will reduce. What I fear is that less and less people will go into global health because, there is, no global health, right? There's no funding. And in the paper, we have a table where we say academic institutions, funders, government decision makers, community, small table that kind of outlines what they can do. And one of the things I think that we need to be intentional about if we need to kind of safeguard our future global health leadership is ensuring there is, funding for these students to come and study. So like if we don't do that, what will happen is that the rich students, right, or the students with social capital, or students with like legacy of wealthy families, or they're the only ones who will be able to access this domain. And then what it will do is it will create another hierarchical system where, even from low and middle income countries, as we know, like, the 1% of a low and middle income country does not necessarily reflect the reality of the people. So, the importance of funding here is that, you give an opportunity for someone who does not have family funds, who does not have the ability to, have that connections with, big schools, to realize their dream, right? You can realize your dream anywhere in the world. But if you want to realize your dream in a specific institutions in a different country, you should be able to do that too, right? So, I wanted to study global health policy, and I'm here because I got scholarships and things like that, and to be able to go to Duke University, to be able to go to McGill University. The funding structure played a role in my success. And I know my mentor, Madhupai, uh, he also, benefited from, and he has spoken about this, from the NIH funds and the Forgot International funds and all these things. So this is essential that we continue this support. This doesn't have to take on an imperialistic model, but we have to ensure that we have genuine bidirectional knowledge flow and infusion of funds to ensure that there is an influx of students, trainees, so that they can pursue their genuine interest in global health. So quality, I don't think it will go down, but it might lead to elite capture of the sector more and more, and then also the sector itself might collapse if we kind of don't do anything about it.
Okay, thank you so much for that. It takes us to the next question because some people feel uh, the global north, especially the US, cutting down international students is basically a funeral on their careers. And I know the impact of this on not just myself, but also people around me. Um, China and some countries
Mhm.
are attracting global talent.
Mhm.
And it's not a news that they're attracting global talent from the United States. What effect will this have on global health?
Um, yeah, so Canada just launched a huge call for high-level global health, actually research scientists to attract all these scientists who are being affected by US policies. I know France did this too, and China is doing it too. So, different countries are trying to, take this as an opportunity to establish itself as powerhouses in sort of research and development and global health policy and all these things. I mean, it's good that these opportunities exist. I would say, I'm glad that it's being spread out to different parts of the world. But I would say, rather than just, again going centering itself into global north, maybe there are opportunities for us to build these centers of excellence in the global south as well. I know there are centers of excellence that already exist, but add more to it, right? um, and I know your question was a geopolitical one. So China attracting expertise will affect the way we approach global health. But if we focus on multilateralism in a genuine way, then we can kind of continue to engage with these countries to advance global health. I don't see China as an enemy or a friend. Like, it's every country is for itself at this moment, I feel like, and we have to counter that. We have to kind of bring multilateralism, so global solidarity back into the center of our conversation. But I don't think China in itself attracting scholars is going to be a problem. Other countries are doing it too. It's just that we have to make sure that we focus on global solidarity moving forward. And that messaging
Thank,
has to be consistent, right? Like it shouldn't be for any one country. Yeah.
Yeah, thank you so much. Global solidarity, that is it. Um, please can you give us three recommendations you and other authors have on sustaining um, training of future leaders in global health?
I would recommend one paper that I wrote with Madhu and Catherine Kyobotungi. It's about shifting power in global health. It's in the Lancet. It was published last 2024 November. I think it's called Shifting Power in Global Health, Leadership by the Global South and Allyship by the Global North. And obviously, I would recommend reading this paper that we published in PLOS Global Public Health, which is titled Disinvesting in the Future. Let me get the title correct. It's called Disinteresting in the Future Leadership of Global Health Has Already Begun. What can we do about it? So if you're a young scholar, I think, or even a PI, a principal investigator, this is something you can look at. The third article I would recommend is related to visa and passport inequities. So I think, this goes under the radar oftentimes because, people in high income countries are not affected, because their citizenship is based there and, they're like, oh, okay, what is the problem? Right? Like, so there are so many articles that have been written around it. We wrote a piece way back when about visa and passport inequities in global public health. But I would recommend a recent one that is very relevant to the policy decision that Trump made. It's called, let me, I always forget these titles, so I'm going to Google it and make sure I get it the right one. Uh, Give me a second. Yeah. So it's called Global North is increasingly unsafe for global health meetings. Uh, it's written by myself, Madhupai, and a refugee from Kenya. Uh,
Neil James.
yeah, Niall. And so I recommend reading that as well. These are three papers that I'm involved in. But I would also recommend reading Shea Bimbola's Foreign Gaze. And there are so many other articles that I can recommend. But I'm going to stop here and like leave at the four, right? So.
Thank you so much for the recommendations. I'm sure anyone who enjoys this is a very beautiful conversation after reading the publication to get more insight on global health leadership within other publications which you gave suggested. Lastly, we are looking at Africa has developed the Africa Health Security Agenda. Where do you see global health leadership investment in the next decade?
So I see two things happening. If you take like the broad, oh, so policy and governance. And I have to say at the outset, I'm not African, so take my, perspective with a grain of salt, and I defer to the experts in the African region always. One thing I would say is we are seeing a unification of countries. Like I said, there was a meeting in Accra, there is, the Lusaka agenda, all these
Yeah.
things are happening. And African Union is doing a great job of trying to, bring the countries together to push the agenda both at the global political decision making, but also making sure that there's increased investment from countries and also in the region. But at the same time, this America First Global Health Agenda is also gaining traction, right? Kenya just signed up an agreement with the US, and there are a bunch of other countries that is signing up. And so we have to see like how that impacts this, regional unification, and will it impact the political decision making within that system? How do we balance the immediate needs and against the structural change that we want to make in the region. So those are the two things I would watch out for. And if a government, uh, stakeholder is ever listening to this, I think I would say that please invest in your own health systems and try to have more power or effort in agenda setting in global health architecture and decision making.
Thank you so much for that, Dr. Shashika. I'll close this session, this discussion with this saying, we can, when you, I don't know if it's an African proverb or where it came from, talking about the broom, you can break one. It's so easy to break one, but when it's in unison, it's so hard to break. And in as much as we're talking about global health leadership, it's important to start from ourselves because you can't give what you don't have. And also, it's so bad giving out what you need. So the advice, the policy, the investing, the collaboration has to start from your country before you export it out. So we need, at this point, not just the global north, not even just the big players in global north and then global health leadership. Every country will have to find a way to make sure you're philanthropists. I don't want to call out now, but there is a big billionaire in Nigeria, the last AFCON, African football tournament in Africa. He gave the footballers $500,000, and it was like if they had won for each score, it was going to give them $50,000. And this is something I was advocating on Twitter. This can give the money to medical doctors. The health system needs this money. So I'm not saying I don't know if he's investing in global health. I don't know if he's doing that and it's not in the news. But what I'm saying is we need philanthropists. In every country has philanthropists, no matter how poor a country is, they have philanthropists. They have the big players in themselves that can contribute to global health. So not just, it starts from in, the collaboration, the policy, the advocacy, everything starts from in. And when you find that when every country focuses on themselves, when every country focuses on developing themselves, when every country has the intention to have a positive global health at national level, global health outlook, you find that when we come together at the end, we have a very big upscaling of global health leadership and impact. So it's in a scenario where you see a country is selfish, they're saying me first, and another country say, okay, not me first, I want to give. That's why you find imbalance between selfishness and generosity. So thank you so much, Dr. Shashika, for sharing your expertise, for sharing your time, for sharing your knowledge with us on global health leadership. So global citizens, Dr. Fajembola'S Opinion is a platform where research meets understanding. This is one of the programs under the Fajembola Initiative of Science and Technology, and we're looking at amplifying research across the global north and south, especially the global south, where there is so much less research coming from the global south. So thank you so much again, Dr. Shashika, and thank you so much, global citizens, for joining us on this episode of Dr. Fajembola'S Opinion. Please not just listen to this, read and also discuss with your colleague. These are discussions. This is a way we can create impact. Discussion. We are not invisible, as we discussed earlier. This is a way you can create impact by discussing and making changes in our global health ecosystem. Thank you so much and have a blessed week, everyone.
All right. Cheers.